We all know from the pathogenesis of rheumatoid arthritis that there are certain cytokines which are special proteins that are high in a person's blood that has rheumatoid arthritis. So biologic DMARDs actually target those molecules. Biologic DMARDs are administered differently. We can have them self-administered in the form of an injection that a patient can give themselves. Most of them, they come in a pre-filled syringe or an auto-injector pen. Then we have certain biologic DMARDs that are given as an IV infusion. Obviously, for those kinds of biologic DMARDs, the patient has to come to a healthcare facility. So we have a type of biologic DMARD that targets TNF-alpha. Then there's another type of biologic DMARD that targets the receptor to IL-1. Then there's another type of DMARD that targets the receptor to IL-6. Then we have biologic DMARDs that decrease B cell production. So B cells are also thought to be involved in the pathogenesis of rheumatoid arthritis by producing antibodies. So we have a biologic DMARD that's given as an infusion, which decreases the production of B cells. We have another category that prevents the stimulation of T cells, and that is known as a T cell co-stimulator blocker. And the thought behind it is that if we don't activate the T cells, then we'll have less inflammation. So when I prescribe a biologic DMARD to my patient, I do tell them that the idea is to be on it for as long as it's providing relief of your symptoms, which could be months, it could be years. It's not known. I also tell them that you have rheumatoid arthritis, which is not curable. It's treatable, and it's treatable with the idea of preventing destruction of joints. So they have to stay on it. So I do make it a point to tell my patients that once the inflammation is controlled, they will see a noticeable change. Their joints will move more, they'll have less pain, they'll be able to enjoy their lives.